Recording in progress.
We're now recording. So, today we'll be going over Chapter 13. And Chapter 13 is going to be... hold on right quick. Sorry about that. All right, so today we'll be going over Chapter 13. There'll be a quiz on it, opening up tonight, as well as your Module 2 quiz will be opening up tonight and will close on Saturday. Okay, so it'll close on Saturday at 11:59 p.m. or 23:59. Your Chapter 13 quiz will be closing on Friday. All right, everybody got that? Chapter quizzes, 48 hours. Module quizzes, 72 hours. Yeah. I had to stop for a minute. All right, so Chapter 13, Vascular Access and Medication Administration. All right, so today, just looking at that, vascular access. That's whenever we're gonna start poking, right? I'm gonna try not to get too far into this, mainly because this weekend at your boot camp you should be getting into a lot of this, or somebody should be going over all of this with you. I'll go over some of it just to give you a good familiarization, and I'm sure all of you do have good familiarization as it is if you've worked on a truck or around medical equipment, or if you've worked around, IVs or anything like that. This is an IV. It's just a needle for a syringe. But I was gonna use it today, if it'll focus in there. If not, then well, crud. So I won't worry about that today. I'll bring up a good picture or something. I should have brought a chest needle decompression kit. That's a much bigger needle. I'm sure I got one downstairs somewhere. All right, so we'll be talking about vascular access and medical administration. It is going to be fun. All right, I'm going to skip over a lot of this. Maybe not so much that. All right, so before you administer medication to a patient, you must have an understanding of how the medication will affect the body, right? We've talked about pharmacokinetics. We've talked about pathophysiology. This is kind of the build on for it. Hey, Mr. Wade. So it's also going to be true it's also going to be true of medications belonging to the patient that you may assist the patient in taking. This includes familiarity with the medications. So you need to know the medication's mechanism of action, indications, contraindications, routes of administration, dose, adverse reactions, and what to do in the event of an adverse reaction. Okay? So one thing, did anybody make for the list of drugs that we got, that we have, did anybody make cards? Anybody make any cards? Yay, nay? Okay, so what we'll wind up doing is I'm going to do an assignment that's going to be making of the cards, making up cards, and of the list of medications. And so what I'm going to have is I'm going to build this assignment out to where everybody will make up cards for the medications that you can give, right? And then I might put in some odds and ends of ones that you may see earlier. So, or you may see while you're out there. But it's very important. You got to learn those. All right, moving on. All right, so the first rule of medicine, do no harm, right? You got to ensure that a particular medication is clearly indicated to treat the patient's condition. And a careful assessment of the patient will help you ensure that only beneficial medications are administered. The IV therapy is one of the most invasive procedures an AMT learns. It's one of the most invasive. Few procedures will require more training or practice than IV. And so it's going to take a lot of practice to get good at it. So proficiency in IV therapy and technique, all about that technique, is required for most procedures administered in advanced life support. So you constantly have to practice, hone your craft, right? So one of the things is some of the things you'll look at is the very basic. At the very basic, be familiar with your equipment, and that's down to. Sorry, I may be. See if we can see this. All right, so being familiar with your equipment. I don't know if everybody can see this or not. Come on. Nope, too much. I don't know why I buy a camera and it won't let me see a needle. I guess I should have asked that whenever I got in. I've had plenty of IVs put in me from students and everything else. They don't do that much anymore. A medical problem of any type alters the established balance among the systems of the body, right? So homeostasis produces optimal physical performance. Homeostasis produces optimal physical performance. Now, optimal for that patient, okay? And then healthcare provider, they must fully assess a patient's condition, identify and treat life-threatening injuries and illnesses that alter homeostasis. That is your position. That's your job there. So you must also have an understanding of basic math for pharmacology to calculate the appropriate medication doses. Drug doses and flow rate calculations are common areas of confusion for many pre-hospital personnel, mainly because a lot of pre-hospital personnel are out of practice for it. They're skilled. These are going to be skills that will perform that you'll need to perform frequently out in the field. It's going to happen all the time because you're giving medications, you're giving fluids. You need to learn those fluid rates. Don't just hook them up and bolus. You're hooking them up and you're going to bolus everybody. You're going to titrate for effect everybody. You need to have a knowledge of what you're doing. You need to have that math put in your head already. As an AMT, you must learn to quickly and accurately calculate the doses to maximize the chance for a positive patient outcome. If not, then disastrous results can take effect, such as death. That can occur. If you administer an inappropriate drug or inappropriate dose, if you give a medication by the wrong route, or if you give a medication too rapidly or too slowly. You got to know what's a slow push and what's a rapid push. You got to know those. D50, right off the bat, D50. Does anybody remember what the push rate is on it? Does anybody know that? Slow. Oh, okay. Yep, slow. Slow. But how slow is slow? So, if we're talking slow, man, I need my kit. I need my training kit here. If we're talking slow, then are we meaning slow like this slow? Or do we mean slow as in something like this slow, where you're flowing this? It should take you almost 5 minutes to push that thing in. Over 5 minutes, over 3 to 5 minutes, right? So, and you'd be surprised, and you'll see it time and time again, nobody, they're like, well, hurry up, we're gonna slap this in there and everything else. And Ty, if Ty feels comfortable, I really do think that he should share in the files, in the file section here. If you look in your chat over in the right hand corner, you see a little file there. I think he should share his little excerpt, the excerpt on D50 that we did the other day. It's fantastic insight. So if Ty feels comfortable doing so, I think it kind of gives you some insight as to, how you should, and it not just D50, but how you should administer all medications with care and to responsiveness, and don't just throw it in there because that's what the book told you to throw in there at the rate that you told her to throw it in. Man, you've got to pay attention to your patient. How much does your patient need? How much, what is the individual? Not every patient's the same. They did not write an SOG that was meant to cover every single scenario. So you need to do that. How do I accomplish this? So if you have it on a Word document or something like that, then you can take and you can hit this. If you look on the chat right here, you see right there to the right next to the smiley face, this little paper with the corner bent down. You can hit that and actually go to your computer if you have it on there, or wherever you have it at, and you can put it. You can just go to your computer, look it up, put it in, and it'll be good to go. Got it? Yep. It's fantastic. It's not, doesn't take a lot out of your time, and I thought it was very good insight as to how a patient should receive medications, or it'll kind of help you make better decisions as a practitioner or a provider. You are a practitioner. You do practice. All right. So medical direction, we have pounded this in the first couple of chapters, right? So medication administration it's going to be governed by your local protocols and online med direction. Your medical director for your service may allow the administration of certain medications if the patient meets certain criteria. Most EMS services carry drug boxes with a variety of cardiac medications, pain medications, anticonvulsants, antiemetics, other types of medications specific to their service, so on and so forth. So you also have what's called standing orders. We've talked about it's a form of offline and indirect medical control. They're standing orders. That's something that you should have already, ready to go. You should know those. I can do this because my standing orders say so. AMT performs certain predefined procedures before contacting the physician if they have standing orders. Some EMS systems, medical directors require AMTs to contact them before preparing or before performing certain procedures, and that's what we call online medical control. So, like I say, this is just a review. Local policies and procedures are designed to guide you in that specific, in those specific situations. So, make sure you know them. AMT's responsibility associated with drug orders. The danger of something going wrong when administering a medication can be minimized by... I need a trash can up here. It can be minimized by confirming the 10 rights of medication administration. Used to be 5, right? Now there's 10 rights, right? So, right patient, right medication, right dose, right route, right time, right documentation and reporting, right assessment, right to refuse, right evaluation, and right patient education. So you got to let the patient know, hey, that's one thing too that we don't do. We grab a medication and we start, we spray it in there or however we're doing it. We need to let the patient know as we're getting this stuff together, hey, I've got this type of medication. I'm giving you this because of this. I feel that this would do, this would do you well. This is the effect that this will have on you. These are the positive effects, these are the negative effects, and this is why. And at some point during that, you may have a patient be like, oh, I forgot to tell you that I can't have that because I'm allergic to it, or I can't have that because my doctor said that it's going to interact with such and such. If you don't do that beforehand, then you may pop that off in there and it have an adverse reaction, which is not good. I'm allergic to epinephrine. I don't know if y'all have had a chance to hear something like that yet. I'm allergic to Toradol. I know that's a pretty common one. Procedures for administering any medication is going to be like, it's going to go something like this. You're going to obtain an order from med control. It may be given directly through offline medical control via telephone or radio. It may be indirect through protocols that contain. Yeah, it may be indirect through protocols that contain standing orders or administration of certain medications for the administration of certain medications. And when you're communicating with medical control about administering a particular medication, make sure that the medication is indicated for the patient's condition. The knowledge of each medication that you carry in your ambulance is critical to safe patient care. So you need to know the indications, contraindications, therapeutic effects, side effects, and appropriate doses. Okay? So let me repeat that. You need to know the indications, the contraindications, the therapeutic effects, the side effects, and the appropriate doses. Okay? And then know when and when not to administer that medication. That's very important. If you don't learn anything else here, learn that. Because medication administration will end your career if you are not careful. Make sure medical control understands the whole situation, and then you tell them what your request. You tell them what you plan on doing, and make sure you know what you're talking about. Make sure your information is correct when you tell them. Tell them what you plan on doing and how you plan on doing it, and then they will say, "Yes, do this," or they will say, "Wait, let's not do that," or they will say, "You can do this, but let's look at this as well." Whatever they want to do. But if you tell them what you're going to do, what you plan to do, if you tell them what you plan to do, and you're confident and you are knowledgeable about what you plan to do, you are going to build a good rapport with that med direction. And at that point, you're in. You're in. Your job will get so much easier. So make sure also the decision to order administration of any medication it's very complex, and it should involve consideration of the patient's age, weight, clinical status, allergy history, and then any type of concomitant, any medical problems they may have, other drugs that they may be taking as well. You need to know that. It's critical that you obtain. It's critical that you obtain and communicate complete, accurate information about the patient to the physician, right? So you got to verify your patient is the right patient in situations where there are multiple patients as well. If you're assisting a patient with his or her medication, be sure it is prescribed to that patient. Be sure it's prescribed to that patient. The easiest way to do that is you look at the bottle, you ask them, their name, date of birth, just like you would at the doctor's office. If they don't have it, I would be wary. I'm not saying don't do it, but I would be wary of giving a medication that's placed in a cookie jar or anything of that type of nature. I'd be wary of that because it's hard for me to know is that actually theirs or not. Or if it's out of date. There you go. Ty put it up there. It's good stuff. Make sure you understand the physician's orders. So read it back to them. So whatever they tell you to do, say it back to them. That way they know. Word for word. And then make sure you dispose of any syringes and needles safely. So you'll see some people that take this needle here, and then they will fold over that needle, right? They'll fold it over and then put the cap on. Don't do that. Don't do that. Or something else that they'll do is they'll take and they'll try to recap it, right? And then end up poking themselves. So you want to make sure that when you recap it, that you shouldn't have to recap it. You should just be able to take that needle and throw it in your sharps container. You shouldn't have to recap it. Recapping needles is what causes most exposures. Is recapping needles, pulling this mess right here, right? So always document your actions and the patient's response on the patient care report after administering any type of medication. You need to put the name of the medication, the dosage of the medication, the time you administered the medication, the route that you administered the medication, your name or the name of the person who administered the medication, and then the patient's response to the medication, whether positive or negative. So something that I might put, for instance, is I might say something to the effect of performed IV insertion in the right AC. And I might say 18 gauge, 18 gauge with a, I don't know, 10 drop. Now, and you get all the way down to it. What tools you use and everything. With a 10 GTTS, if you're saying right AC, if you're saying right AC, R, and then AC, right? Remember those abbreviations that you can use? RT, AC. Use 18 gauge, 18G. If you're using a 10 drop set, then you may say 10 GTTS. So on and so forth. Use the right. I was going to write it, but none of y'all will be able to read my writing. It's terrible. So, as an AMT, you may administer the following. If you want to write this down, if you can write this down and kind of get a head start on your cards, right? So, this is what we're going to do. So, as an AMT, and I'm going to put it in the chat as well. Whoop, I didn't mean to do that. Oxygen, oral glucose, glucagon, whoops, I spelled that wrong, dextrose or D50W. The IV fluids that you can give are going to be D5W, which is what? 5% dextrose, right? You're going to be able to give a drug called normaceline. Does anybody remember what normaceline is? And LR. Normaceline, normal saline. Yeah, that's something too. Jokes with your patient, what have you. I know that if you tell a patient when he asks, "What are you giving me?" and you say something like, "I'm going to give you a little bit of normaceline," that can actually get you in trouble at some of these companies because it causes undue stress on the patient. It's not very professional, and so they can actually you can actually be fired for telling a patient that you're going to administer something like normaceline to them, and so on and so forth. Even though it's completely innocent, it's just a joke or anything else. Somebody wanted to bring it up, that could actually get you in a good bit of trouble. Epinephrine. Buterol. Nitroglycerin in the spray. Tablets. Paste. Nitrous oxide. Naloxone. Aspirin. And then you may have other medications that you can administer based on your local protocols also. Yeah. Recall that you may only administer or help these medications when allowed by local protocol or ordered by a licensed physician. That might be in your local protocol, but it is not on my list of meds. All right, so basic cell physiology. Before we get into this, let's take a 10-minute break before we get into this, because this mess is long.
on WGU with a 92%.
All right, 10 minutes. See y'all in 10 minutes. Bye-bye. All right. All right. We're back. So, getting into the basic cell physiology, we went over this back in a few other chapters. Um, Mostly, what this will get into is more of the acid-base balance and selective permeability of the cells, and so it'd be something in your book to read over. There are definitely enough. There are enough YouTube videos on the selective permeability, mostly on the sodium potassium pump. Uh, we'll go over that a little bit. I do have a video on that that's pretty good. It could explain it better than I can. All right, so sorry I went too far. So atoms carry charges, positive or negative. Two or more atoms bond together to form a molecule. Molecules containing carbon atoms or organic molecules. Molecules are organic molecules. Molecules created without carbon are called inorganic molecules. Okay? Inorganic molecules give rise to electrolytes when they dissociate in water into their charged components. Electrolytes or ions are reactive and dangerous if they're left to circulate in the body. Water in the body helps to stabilize the electrolyte charges so that the electrolytes can be used to perform the metabolic functions that are necessary to sustain your life. All right. There's some other terms that are used. Cation, which an electrolyte with an overall positive charge there. Anion, an electrolyte with an overall negative charge. Anion, right? Sodium says there is the principal extracellular cation needed to regulate the distribution of water throughout the body in the intravascular and interstitial fluid compartments. It's a major factor in adequate cellular perfusion, and sodium is also a major component of the circulating buffer, if you remember us talking about that. All right, so hypokalemia, we've talked about that. That low potassium can result in a decreased skeletal muscle function and GI disturbances, as well as alterations in cardiac function. Hyperkalemia can result in hyperstimulation of the neural cell transmission, resulting in cardiac arrest. High potassium. We talked about hyperkalemia too, and what that looks like on a EKG. If you remember, the QRS is the QRS, and then the T wave. If the T wave is 3/4 the length, right? Elevated T wave. But what's elevated? So elevated T wave for hyperkalemia is 3/4 the height of the QRS. 3/4 the height of the QRS. Just some gee whiz. All right, there's some other ones there. So calcium's the principal cation needed for bone growth, and it plays an important part in the functioning of the heart muscle, nerves, cell membranes, and blood clotting also. Hypokalemia or low calcium, or I'm sorry, hypocalcemia or low calcium, it can result in overstimulation of cells, resulting in skeletal muscle cramps, abdominal cramps, carpal pedal spasms, hypotension, vasoconstriction, and then you have hypercalcemia, which is high calcium. It can result in decreased stimulation of nerve cells, resulting in things like skeletal muscle weakness, lethargy, ataxia, vasodilation, and hot flush skin can also be one of it. Bicarbonate levels are related to the conditions of acidosis and alkalosis in the body, if you remember that, sodium bicarbonate. And then chloride primarily regulates the pH of the stomach. Phosphorus is an important component in the formation of adenosine triphosphate, or ATP, if you remember that term. All right, so balance across a cell's membrane. Water and electrolytes move among the... Yeah. So water and electrolytes move among the body fluids compartments according to some basic chemical and biologic rules, right? Balance across the cell membrane has two components. The first one being balance of compounds on either side of the cell membrane. The second being balance of charges on either side of the cell membrane. So, as it says in the slide, materials flow from an area of higher concentration to one of lower concentration, establishing what's called a concentration gradient. The process of flowing down a gradient depends on whether the cell membrane will allow the material to pass through it. And this is where we get into diffusion. So filtration, it's a type of diffusion that's used by kidneys to clean the blood. And water carries dissolved compounds across the cell membrane of the tubules of the kidney, where the dissolved compounds are going to be trapped at. So there's active transport there. A method used to move compounds to create and maintain an imbalance of charges. An example of this is going to be, like you see here, the sodium-potassium pump. The cell uses sodium outside the cell and potassium inside the cell for, like, as in potassium inside the cell as in depolarization. Cell uses it in the form of ATP and actively transport compounds across its membrane. If you get into paramedic school, that's like a day and a half worth of lesson. Just the sodium potassium pump. It will drive you absolutely insane thinking about it. But once it clicks, it clicks. So osmosis there. Moving in and out, right? In and out of the cell membrane. And we're going to do that through the tonicity of the solution, right? So the effects of osmotic pressure on a cell. So you got isotonic solutions that have the same concentration of sodium as does the cell. You have hypertonic solution, has a greater concentration of sodium than does the cell. And then hypotonic solution has a lower concentration of sodium than does the cell. And there's a good photograph of it there. All right, so extracellular component is broken down into two sub areas. You got intravascular water portion of the circulatory system surrounding the blood cells. You got interstitial water outside the vascular system and between the surrounding cells. It acts as a buffer between the other compartments. There are three fluid compartments in the human body: the intravascular compartment or extravascular, the interstitial compartment or extracellular compartment, and then the intracellular compartment. Extracellular fluid occupies any area that's not inside the cells. It's extra, right? Extra outside the cells. The ECF, as it's called, extracellular fluid, as it's called, the compartments act as conduits for transferring gases and nutrients between vascular and interstitial fluid compartments. The ECF is found in the interstitial and intravascular compartments, both of those other compartments. The ECF levels are regulated by the presence of sodium. Interstitial fluid accounts for 16% of total body weight. It occupies the microscopic small spaces between the cells. It consists of a gel-type protein that helps disperse the water evenly through the interstitial compartment. It helps water move freely between the cell and the vasculature. So perfusion. This occurs in the capillaries as a result of high hydrostatic pressures and osmosis in the capillary beds. So intracellular fluid, or ICF, within all cells of the body, and large proteins within the cell can draw fluid into the cell. So depletion of the body's total systemic fluid volume is dehydration. It's more common in older adults and young children. It may take days to manifest, and it could be the result of a certain type of medical condition as well. As fluid is lost from the vascular compartment, the body reacts by shifting interstitial fluid into the vascular areas. This force of shift of fluid from the intracellular to the extracellular compartments, and then at that point, a total systemic fluid deficit occurs. Some of the signs and symptoms you may see, they're here listed, and then some of the signs and symptoms also include a listing that you see here, also. And some of the causes of that are listed right below it. Some of the causes of that dehydration. Excuse me. Overhydration is a result of a total systemic fluid volume increase in the body. Thank you. The fluid fills the vascular compartment and filters into the... I don't need one now. I went and got my vaccine yesterday. You know, you can't get it now. So the fluid fills Pfizer. Got the Pfizer one. The fluid fills the vascular compartments and filters into the interstitial compartment, and is forced from the engorged interstitial compartment into the intracellular compartment. Fluid backup, this can result in death, so something you got to watch out for. The signs and symptoms are going to include shortness of breath, puffy eyelids, edema like you see here, the pitting edema test that they have here that was done here. Polyuria, which just means you pee multiple times. Moist crackles in the lungs when you're hearing it. Then also acute weight gain, so sudden weight gain. Some causes of this can be unmonitored IV lines. That's why I talked about you can't just bolus your patients and let her eat. Kidney failure, and then prolonged hypoventilation can cause it as well. All right. So IV fluid composition. IV solutions are tools designed to facilitate patient treatment. The use of IVs can significantly alter the patient's condition, for good or bad, depending on how you use it. If you use it correctly, good. Compounds and ions dissolved in the solution are identical to the ones found in the body. Each solution is a concentration of solute and solvent. Sodium's used as a benchmark to calculate a solution's tonicity. Sodium is. A concentration of sodium in the cells of the body is approximately 0.9%. Sound familiar, right? 0.9%. A common IV fluid that AMTs administer is normal saline. Altering the concentration of sodium in the IV solution can move the water into or out of any fluid compartment in the body. So here's some good stuff about IV. So types of solutions. You got IV solutions. They're categorized into crystalloid or colloid based. It's based on their dissolved components and makeup. A crystalloid solution is dissolved crystals in water. Crystalloid, dissolved crystals in water. It contains compounds that quickly dissociate into or in a sodium, or I'm sorry, that quickly dissociate in a solution. It's the best choice for the pre-hospital care of injured patients with body fluid loss. So 3 milliliters of isotonic crystalloid solution is needed to replace 1 milliliter of a patient's blood. Let me repeat that. 3 milliliters of isotonic crystalloid solution is needed to replace 1 milliliter of a patient's blood. It doesn't have the capability to carry oxygen, though, so you're not just going to try to make Kool-Aid, right? A bolus is a single dose given via the IV route. Remember this when we talk about boluses, in case you didn't know. Boluses of 20 milligrams per kg. So 20 milligrams per kg should be given to maintain perfusion. Radial pulses, or to maintain those radial pulses, but not to raise blood pressure. Increasing blood pressure with IV solutions, it dilutes the remaining blood volume, and it may decrease or it may increase internal bleeding by interfering with homeostasis. It's going to interfere with clotting factors, things like that. Yeah. Colloid solutions, they're going to contain molecules, usually proteins, that's too large to pass out of the capillary membranes that remain in the vascular compartment. It has a very high osmolarity. It'll draw the interstitial and intracellular compartments into the vascular compartments, and it works well in reducing edema while expanding the vascular compartments. It could cause dramatic fluid shifts and place the patient in considerable danger if they're not administered in a controlled setting. It's got to be controlled. Isotonic solutions. Three categories related to tonicity are isotonic, hypotonic, and hypertonic. Isotonic solutions, such as normal saline, possess nearly the same osmolarity as serum and other bodily fluids. Osmolarity indicates how easily or not water will move, right? Um, Isotonic solutions expand the contents of the intravascular compartment without shifting the fluid to or from other compartments as well. Uh, the fluid remains in the vascular compartment, so be careful to avoid fluid overloading at that point. Patients with hypertension and heart failure are at greatest risk of fluid overload. Remember that. And lactated Ringer solution is generally used in the field for patients who have lost large amounts of blood. LR, good old LR. D5W is a special type of isotonic solution. As long as it remains in the bag, it's considered an isotonic solution. After administration, the dextrose quickly metabolized, and the solution then becomes hypotonic. All right, so hypotonic solutions, transitioning into. Hypotonic fluid has a lower concentration of sodium than the cell. Uh, it hydrates the cell, or it's going to hydrate the cell while depleting the vascular compartment. It may be needed for a patient on dialysis when diuretic therapy dehydrates the cells. All right, so it's dangerous to use because they can cause a sudden fluid shift from the intravascular space to the cells. It's also dangerous to use on patients that are experiencing a stroke or head trauma, or patients with burns, trauma, malnutrition, or liver disease. Hypotonic solutions are dangerous for that. All right, hypertonic solutions. A hypertonic solution has an osmolarity higher than serum. It has more ionic concentration than serum, and hypertonic solutions shift body fluids into vascular space and pull fluid and electrolytes from the intracellular and interstitial compartments into the intravascular compartment. It's going to help stabilize blood pressure and increase urine output and reduce edema, which is, what we're trying to do, or that may be something that we're trying to do. It's rarely used in the hospital setting, though. It's mostly used in the hospital. And then it often refers to solutions that contain high concentration of proteins. You have to be careful. Because you gotta monitor this closely, and you have to monitor it because you got to guard against fluid overloading. It shouldn't be given to patients with diabetic ketoacidosis or others at risk of cellular dehydration. All right, so techniques administration. You're going to keep the IV equipment sterile in the truck. Okay. You're going to keep this stuff sterile. And you're going to develop a routine as you assemble the appropriate equipment. That's going to be the important thing, is that process that you do things, how you set up that IV equipment. You do it the same way every time, you're not going to forget things. When you first start, you're going to stumble, you're going to forget some things. You're going to be like, oh crap, I forgot this. Oh crap, I forgot to cut tape. or I forgot to pull some tape. Prepare that tape, have that band, make sure you take the band off. Yeah. Just there's all sorts of things that you got to remember as you're going. And you'll remember all these procedures as you go. Or as you learn, the more you practice it. So, to assemble your equipment, you're going to prepare all your equipment before you attempt to start an IV line. This equipment is going to include an elastic constricting band, or what we call the rubber band or the tourniquet. That's what most of us call a tourniquet, even though it's not an actual tourniquet. An antiseptic wipe or some sort of solution. And then you're going to have gauze, right, for blood, right? You may want to have those 4x4s is generally what we use, 4x4s. And you're going to have tape or adhesive bandage. What I generally do is I pull 5 to 6 strands of tape about 6 inches long. About 6 inches long a piece is what I generally do, depend on a normal IV, on a usual IV, let's say, the most needed. So I'll use about 5 or 6 pieces of tape. I take one of those pieces and I actually half it long way, hot dog ways, so that I can make a chevron, and a chevron is going to be used to hold it, to hold that IV in place. And you may be able to find that somewhere, holding that chevron up there. From there, you'll have your tape or adhesive bandage, or you may have a tegaderm, and then you'll have the appropriate sized IV catheter. So whatever you need for whatever situation you're in. You'll have your IV extension set, which is going to be your drops. Is it going to be a 60 drop, or are you going to have a 10 drop? That's generally what's used around here. And then, or if you have a blood set, or if you have, there's all sorts of sets. You're going to have a saline flush. So the actual flushes here. Oh, man. And that's what we call a flush there. 10 mLs, right? 10 milliliters. And then you're going to have your IV administration set. Okay. So generally what I do is I take the IV, once I get the IV out of the packet, I take the IV itself and I make sure that it can move. Okay? I make sure that it can move, and that needle can move on that catheter, and I twist the catheter. And I just twist it on there just to make sure it's loose, because sometimes it'll get stuck. So when you go to push that, when you go to advance that catheter, it'll be stuck on there, and then you wind up having to grab it with 2 hands, and then it's a pain in the butt. So if you take before you start and you just give it a little twist just to make sure it's loose, then when you push, it's good to go. It's not stuck at that point. So there is a table in your book that's going to show you the logical sequence of steps. All right, next you'll choose your IV solution. And then you'll choose your administration set. So what happens a lot of times is they'll take that administration set and they'll put it on there, and they won't make sure that it's flushed out, right? You got to flush it, because you don't want to hook it up to the IV and have it and not have it flushed. You want to have it pre-filled with that set pre-filled. So you can see the one on the left is empty. So all you got to do is you take and then you squeeze that bulb. You squeeze that little plastic piece there, squeeze it, and it'll fill up. Now if it fills up all the way, all you got to do, turn it upside down and squeeze it a little bit, and it'll leave you a little bit of room, because that's what this portion right here is where they get the drops from. Okay, so this is where you count your drops and your flow rates. All right, now there are quick ways to do it, to doing this. but that is where they get the drops from when you count them. Some people will squeeze it and it'll fill this fluid all the way up to here, and this is what I was talking about. You can turn it upside down and squeeze it again back into the bag, and it'll squeeze it back in the bag and squeeze this out here, and it'll leave this little bit of gap. So you can actually get a good count if you needed to. So drip sets, they come in two sizes primarily. You got your 60 GTT, which is 60 GTT per milliliter, and or drops per milliliter. It's small, needle-like orifice. It's inside the drip chamber. Ideal for medication administration or pediatric fluid delivery. It's easy to control their flow on those. You'll also have a macro drip, which allows 10 to 15 GTT per milliliter. It's got a large opening between the piercing spike and the drip chamber. It's best for rapid fluid replacement. You also have blood sets. It's a special type of macro drip set, and there's a picture of it there on the right. It's designed to facilitate rapid flow replacement of manual infusion of multiple IV bags or IV blood replacement combinations. Most sets have dual piercing spikes that allow 2 bags of... What am I doing? It's going to allow for 2 bags to be hooked up to it. And then to prepare that administration set, to prepare to spike the bag administration set, you can follow that the skill drills in 13.1. in your book. So choosing an IV site, it's important to select the most appropriate vein. I would start, you may see veins that are real big, right? I would start low and then go high, because once you make your stick, if you fail at sticking that AC, let's say, you can't go lower. You're not supposed to go lower. Now, do people do it? Yeah. But you're not supposed to go any lower, because what's going to happen? You're going to flow into that, and it's just going to out of the hole. That's ridiculous, right? So you want to start low, maybe not the hand all the time, but start low and then move up. Forearm is a good one as well. Here, it gets real kinked up. It could get kinked up pretty easily. Here, it's less likely to get kinked up. If you do it in the wrist, good luck. You may have somebody PO'd at you when you get done. Generally, they say that hurts. So generally what I do is I put it on the wrist and then wrap it around the thumb, or I'll wrap the line. The line will come around the thumb and everything else. Main point is you want to tape it up enough to where it's not going to yank out. Veins, they say they feel spongy or kind of springy when you touch on them. And they do for some, but it takes a while to get used to them. In darker complected people, and people that are real dark complected, sometimes it's harder to find, and you do have to rely more on feel. So, what do a lot of people do? What a lot of people I see them do, they'll take that glove and they'll take that finger and they'll pop that finger off. Don't do that. Learn how to operate with your gloves. Wear the correct size gloves, and then learn how to operate with those gloves. Okay? Look at that dude's veins. Whew, son. I could throw one from across the room. He's got pipes. All right, so you can see there some places to avoid. And that's very important, so pay attention to your patient. So you want to avoid extremities that have signs of trauma, because it does no good. It's just going to come out, right? You want to avoid any extremity with a dialysis fistula. And then you want to avoid any extremity that's on the same side, or prior mastectomy or lymph node dissection surgery. What's something else? If so that looks familiar, right? Your avoidances, it looks familiar. Those three types of avoidances. Also, there's another procedure that you'll do as an EMT that you avoid those as well. Does anybody remember? BP. That's right. If you shouldn't do a blood pressure on it, you probably shouldn't get an IV on it. So you want to pay attention to areas of the vein that have track marks, because this is usually a sign of sclerosis, and that's caused by frequent puncture or cannulation in there. If the IV therapy is being given for life-threatening illness or injuries, the choice is often limited to areas that remain open during hypoperfusion, which is hard to find. And if they're out cold, give them the IV. That's right. But you want to, for the most part, you want to start distally and work your way proximally. Now, large protruding veins sometimes can be deceiving in their ease of cannulation. Sometimes they have thicker walls or they roll. They roll quite a bit. Yeah. Anything that you do, you want to stabilize that area before you start. You either want to, like an arm, you want to pull it straight. A wrist, or if you're putting it on top of the hand, you want to take that hand and kind of pull it down a little bit. You can see there in the picture, it's holding the thumbs and everything. Or not the thumb, holding it. The way that they're holding it is like this. I don't know how to make that. That's the way they're holding it. Just kind of like they're holding their hand. Hold on right quick. I'm going to try and go get a dummy. All right, so I brought my wife to kind of help me out with this. You're gonna have to. All right. So whenever you're looking here, the AC. All right. A lot of times, you know, which way are we going here? There. So a lot of times, your main veins that are going to run through here are here on the sides. A lot of times, what you're feel for. And then in the center here. I can actually see one on the center here. You can feel it. Okay? But, like we talked about, you want to start low. So, you can start low, like I have her hand here. I very rarely hold her hand, so she can feel good about this. And then, you can see the top of the hand. These are usually, they're not tough to get, but they're more painful for the patient. You can see good veins here. But the way that I'm holding that hand is I hold her hand like this, so that I can pull. I'm holding stabilization on this. If I'm doing an IV on her arm, if her arm's laid down or on her, I'm gonna pull it straight out with the palm up. Okay, and then I'm gonna make sure that when I hold that, I'm gonna take, if I'm pulling the vein here, then I'm gonna take below it, and I'm just gonna pull that skin a little bit. and tighten that skin a little bit. And then when I come in with the bevel up, and then slide right in. Okay? That's it. That's it. Okay, thanks. Bring Ethan in here. We'll look at his. All right, I have another example here too. All right.
I'll get a shirt.
Yeah, go get it, kid. I was gonna show you my son, but for some reason he can't wear clothes, so he's got to go get clothes on before he can even start to get on the camera. That kid. So kids are a little different, and you'll see what I'm talking about. Now he's a normal sized 8-year-old, so it's, you know, he's not going to be that bad. 8-year-old, they're pretty good. All right, so you see here, a lot smaller, right? If you look, you really don't see veins, right? You don't see a lot of vasculature in his arm. So when I'm looking at his, there's a few things that I'm looking for. Okay, first off, I know that there's going to be veins running here to here, but also I'm gonna put that tourniquet on. Okay, pump your arm for me. Pump it like this. Do this. Squeeze, squeeze, squeeze. Okay, and if I can get it this way, then I'm gonna see that a little bit if I got that on, and I can see a good one here, and I can actually feel a good one here in the AC. Okay. And then I can also feel another one here on his forearm. You notice you don't see a lot on his hand at all. A good spot usually too for kids is up here in this area. You'll see. And then another one for small kids, for babies. Come here, bring your head here. Bring your head here, bring down. Look at the camera. Okay. Right here on top of the head, there's a good vein up there too for small kids. If you can't find them there, then there's other places that you can get for kids. Here, lean in. Here, in this area, sometimes you can see some good veins. And then also there's other places. Let me see your leg. On kids, a lot of times, on the foot, some good places as well. All right. Thank you, sir. Love you. Close the door. Thank you. Some good examples there. I could bring the dog in. We'll find some veins on him. They're used to it. They get used on. They get used for medical dummies all the time. Whenever I was studying or anything else. So choosing the catheter, there's an over the needle catheter, and there's your butterfly sets. Usually your butterfly sets are smaller. As you can see, this one's 23 gauge. Just remember, if you get too small, then if they try to pull any blood or anything from it, you stand a lot more of a chance of hemolyzing that blood, and you can't get a good sample from it. So, and then also you're not given a lot of fluids from that either. All right, so right there in that picture, which part? About the smaller catheter? So if you use what's not a good spot? Oh no. I was saying that I was talking about for your smaller catheters. Like you see here, this is for a vacutainer, but for blood collection. but a lot of times you'll have 22 and 24 gauges. And at that point, you should really kind of decipher whether that's what you want to use. Because if you try to pull a blood sample from that, or if you try to hook a blood container to it, or a vacutainer or anything like that to it, then it's not going to be very good for the blood itself. It'll hemolyze if it comes out too fast or goes through the catheter too fast. It'll hemolyze and destroy the blood, and at that point you can't get good test results from it if they try to pull any test or an ABG or anything like that, if they're using, which they shouldn't be using that for an ABG anyway. But anyway, also it's not good for giving a lot of for giving a good amount of fluids. Sorry, for flow rates, depending if you're trying to do restorative type work. Went over this a little bit. As you can see here, he or she is given a top of the hand to he or she. Now, depending on how this goes, as soon as this person pulls that catheter, or as soon as that person pulls that actual needle, there's going to be a lot of blood come out of that vein. Because why do you think that? It's probably going to be uncontrolled, because they're not holding that vein with their other finger. It's kind of like a water hose. You got to kink or step on that water hose, right, from the flow, because if you pull that needle from that catheter all of a sudden and you don't have that kinked or stopped, that flow stopped, it's going to spray out or it's going to leak out and you're going to have a mess and it's going to worry the patient and everything else. So you got to hold it, and then you put your cap on or whatever you're using. If you're putting a hep lock on, if you're putting a pigtail on, whatever. Or if you're putting your drop set on. If you're putting your drop set directly on there, go ahead and put it on there, then release. But you want to make sure you got your tape ready and everything too, because you want to be able to stabilize. So what I generally do is I'll put a finger upstream here, and then I'll also put a finger right here on that hub, on what's called the hub. And then that way, if I go to twist anything onto it, it'll all be stabilized and I can twist it on there. All right, you can see there, bevel up. So the bevel is up on that. I need a... What else has a bevel? Oh, well. That one's not as good. So you can kind of see the bevel on this. Bevel up. Do you prefer 20 as a normal unless it's trauma? No. I prefer an 18. And on most things. And it's completely, and a 20 is more comfortable for some people for whatever reason. It's not that much bigger, but for, I generally try to use an 18 on everything because it's the most widely used for medications, for fluid replacement, or anything like that. Also, an 18 is good because once that patient leaves you, and say that patient's got to go to X-ray or to CT or anything else, if you have an 18 on there, then they can use that 18 to hook up to any of their fluids on there, because some of their fluids are a little more viscous. The viscosity of that fluid is a little bit more, so it's almost like damn oil. So it will get through that. It'll get through that IV a lot more, and they can use it. Now, no matter what, after a certain amount of time, you got to replace it anyway. But that 18 is very versatile, very versatile. I've been at places where a 16 was the normal use. And it's all about fluid. It's all about fluid rates, what the flow rates are, and you can look up flow rates for certain size catheters, and you can see where the biggest differences are. That 18 to 20, those are common, but I generally try to stick with my greens. Have I ever seen a 10? I've never used a 10. I don't guess I have. I don't guess I have. So I've been with a ambulance company that actually used 16s, and then overseas also that actually use 16s quite a bit, like as their normal. I've seen 10 gauge piercings. Hold on right quick. I wanted to look something up right quick. Where would you see a 10 at? That would be it. Oh yeah. Where was that for? Like I mean, a mortician could use that, I would suppose. Because I mean, think about it. Yeah, yeah. 12. I've seen 12s. I've seen plenty of 12s, 12s, 14s, 16s. But I mean, think about it like this. Most of the time, I mean, a chest needle decompression kit is what size usually for a normal size needle decompression kit? It's 14, right? And that's a pretty big gauge. Really don't need much more than that. So I challenge you to look this up, is to go and look up fluid rates for IVs and for IV catheters, and to see where that biggest difference is. And that's going to kind of help you, because at a certain point, you're going to be making Kool-Aid. You know, you're pumping so much fluid to them that you're going to make that Kool-Aid that we talked about. And blood can't carry, or I'm sorry, those fluids that you're giving cannot carry oxygen. And so if you're just replacing it out there, first off, you're jacking up clotting factors. Second off, it's not going to carry oxygen, so you're going to affect your perfusion as well. So you got to look at that. So you see there, you want to apply the constricting band above the site that you've chosen. Don't leave the constricting band on. As soon as you get that needle on there, boom. As soon as you get that needle in there and you get it secured down and everything, and you start to give that first push, before you give that first push, remove that band. Don't forget it, because it can cause a lot of issues if you accidentally leave that band on there. All right, blood draws are a little bit different. A lot of stabilization there, and you're not leaving a catheter, you're leaving a needle. You're putting a needle in there, so you got to hold it stabilized, and then you got to make sure you put that thing on there. Yeah, exactly. And generally in our area, we use 500s because I'm not using much. Hell, I've used smaller than that. I've used smaller bags because I'm not giving a lot of fluids. I'm usually I'm not going to give on regular patients. I'm not giving 1,000. Hell, most of the time I'm not giving 500. I may give 200 to 300 and that'd be about it. They do have blood tubes, blood sets, because that can be used also. Blood sets can be used not only for blood, but it can be used for multiple drugs that you put on there. So if you want to put up different types of drugs, or that drip, you want to run a fluid and you want to run a drip at the same time of something, then you can use that blood set to do that with. It doesn't have to be just for blood. Now, we don't have blood draw sets, like taking blood draws or anything like that, vacutainer stuff. We don't have that on trucks. There may be some trucks, and I have actually heard of some trucks. Actually, I do know, in the Air Force, in the Air Force, the vacutainers or the tubes, we had those on ambulances, and they would want us to do collections before they showed up. And then I worked also for a level 1 trauma center, that in the trucks that would come out of there at San Antonio, they could do the same thing. So you could take the vacutainers and you could get blood draws from it and then bring it in, and then they could go ahead and get their D-dimers done or whatever test they're going to do for it. Yep. Well, I mean, it depends on how close you are. You do it like you don't have to do it like when you're just getting in the truck. Let's say you're pulling up into the ambulance bay. You can go ahead, you can do your draws, and as you're walking in, that's what we did. As I was walking in, or the EMT was pushing in, I was taking those tubes and I was holding them as I was talking, and then I'd hand them off like, here's my blood draws, and of course they're color coded, and then boop, I'd hand it in. Sure enough. It's for the military. So the SAMC, their San Antonio Military Medical Center, is the only level 1 trauma center in San Antonio. So they work with the city as well. It's open and busy, and it's a teaching hospital as well. So that was the most amazing hospital that I've worked at. Now, other than like Boston Shock Trauma or something like that, but SAMC was incredible at teaching. It was incredible. I got to work with a lot of patients. No, hell no, you ain't gonna do that at Keesler. And like I say, San Antonio's or SAMC's in the middle of San Antonio, and it's a level 1 trauma center, so you get everyone. Keesler's not a level 1 trauma center. So there was a lot more opportunity to get a lot more done while I was there. Oh man, they had us doing everything though. We as a military medic, we doing flight medicine and everything else. We got to do sutures, we got to do all sorts of stuff with our patients. So if we had one come in with a good laceration, I would get to stitch up, and if we had some coming in with other things, you get to do a lot of it. We could do, our scope was way bigger. Yep. Yeah. Butterflies are common for phlebotomy. Now, on the military side, yeah, for phlebotomy, the only problem is, like I talk about, when you get to those small gauges, you can actually hemolyze the blood, because you'll hear it. What I mean? You'll put that on there, and if you've ever put one on there and you can feel it vibrate, it feels like the vacutainer's going bzzz. It's like vibrating. The possibility of that blood being no good is quite high. You should know, that, being a phlebotomist. So whenever I had to get my IV certification, so you come in and they hand you a paper, right? The Air Force does. They hand you a paper, and you have to have 90 IVs before they'll let you start giving IV. So you have to give 90 IVs before you even start. So what they do is they put you in triage, or they put you in blood collection, like a phlebotomist. And then all you do all day long for every patient that comes in is give an IV or take blood samples. And that's how you get your 90, and you get your 90 the first day. Yeah, we had to do 90. So the first day you do 90, and then from then on you do IVs anytime you get put into a rotation. Boom, 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 boom. You just do IVs everywhere you went. Yeah, it was pretty awesome. You got to learn a lot. Some of this y'all be going over this weekend, so I'm not going to go over it. If you do not go over this weekend, please let me know. If there's something that you do not go over that you don't feel comfortable with, please let me know. And we'll go over it as much as I can here to try and get it learned. It's an artery. All bleeding stops eventually. They say 7 to 10 minutes. That's no good. What is that ugly thing there? So if you put an 18 gauge in somebody's arm and then you attach this little dealio right here, what have you now made that 18 gauge? In your usual settings. This is a normal one. Yeah, junk is right. It'll and then also my wife will tell you that it will blow lines. So this here is a Saline Lock. A Hep Lock actually has what in it? A Hep Lock has heparin in it. And that heparin is for KVO. Right. So KVO being keep vein open. That's also part of your documentation. If you put an IV in somebody and then you add IV fluid, but you don't have it cranked up, you got it open just at a steady flow or a very small flow, then what I usually announce that as, or I document that as, is I had the IV for KVO, or fluid rate KVO, keep vein open, and that's what it's for. So something to think about. KVO. I think Bannister will be. And there may be one. I can't remember what the other one. There's one other one I know that's probably going to be there, but I don't know who exactly it is. If I can get out of drill on time, I may go over there. But I'm gonna be at Camp Shelby, so it's quite a drive. And I'll actually be at Camp Shelby on Friday, Saturday. If I can break out of there Saturday, it'd be awesome. There's the fun one. No. We have an assault strip there, remember? And so I go up there and do the assault strip. Those are messy. So that's the EJs, external jugular IV line. Those are messy. Get a lot of fluids in, but they can get bloody. So it's saying here, you can tamponade the vein by placing a finger on the vein just above the clavicle. You can do that. So here's some things if you're having some flow problems. So the first thing you want to do is when you give that initial flush, you don't want to just hook it up then look away. You want to start with the fluid, to get that flush in there. And then as you're looking, just make sure you don't see any swelling or anything like that, because you're looking to blow that line, right? You don't want to blow that line. If you're doing IV, you can get EJ certified. There is no special certification for EJ. Just do it. If you were taught IV, you were taught EJ as well. Now, whether they're going to practice it or do it, like show you how to do it, I don't know. But that you're generally, once you can give an IV, you can give an EJ also. Like I say though, everybody says they're great and good and fun, but they're messy. So possible complications of an IV to follow along or to follow on. Problems can be categorized or local systemic reaction, right? So local IV site reactions, most local reactions require you to DC or discontinue the administration, reestablish an IV line in the opposite extremity, and then you have to document the event. If you miss a line or if you blow a line or anything like that, that's an unsuccessful IV attempt, and you got to put that in there. And the same thing, you got to put what size, everything just like you would at a successful one. You would just have to document it as an unsuccessful attempt. If you have an infiltration, you also have to document that as well. And they happen to some people more than others. I went through a bad string there where I blew a lot of lines. You have bad days and you have good days. There's some signs and symptoms of infiltration. All right, there's some other complications of IV therapy. Yeah, I understand that. So it talks about their proximity to a valve. So your veins also have flapper valves on them too, right? And you can look online at how to find a flapper valve or how to find a valve in a vein, and there's a way to do it on your hand as well. You can take and you can hold that vein up and then push the blood out of that vein, and you'll see where, if it flattens out, you'll know that wherever it stops flattening out, the vein stops flattening out, you'll know that there's a valve in that area. But a lot of times where bifurcations are, where the vein splits off, usually there's a valve somewhere close to that area. If you hit that, sometimes it can be painful, and sometimes you can't get in. Now, some people will what they do is they try to float the IV in. So as they're pushing into the vein, they'll flow a little bit of fluids in. They'll push a little bit of fluids in, and hopefully in hopes that valve will open. And once that valve opens up, then they can just put that IV in there. Sometimes it works, sometimes it don't. But that's not going to be on your test, so we won't get too far into it. There's some bruising there from some bad IVs. Or some blown IVs. Terrible. There's arterial puncture down there. It says there it can occasionally occur. It'll be bright red blood, and it'll be spurting from the catheter after the needle is withdrawn, or it'll back up into the IV tubing into the bag. If that does occur, you must stop that IV, and then apply direct pressure to the site with gauze for at least 15 minutes, and certainly until the bleeding is controlled. So, there's other complications such as allergic reactions. Always know where your diphenhydramine is at, your Benadryl, or your Solumedrol, or whatever you're going to use. If an allergic reaction does occur, you want to DC the IV and remove the solution, whatever you put in there, and then leave the catheter in place as an emergency medication route. Don't remove the catheter, because you may have to put emergency meds in there. Just DC the fluid. And then notify med control and maintain an open airway. There's an air embolus there. It takes a lot of air also. But best thing is to flush. Flush those lines. Flush that syringe. That squirt, that little squirt. Making sure that an empty IV bag, that you replace it with a full one, not a half one. I don't know why you would do that, but why you would. Where did you have the half bag? Is that from a patient that didn't finish theirs? So you just put it in. I'm gonna put this back in the drawer. I'm sure there's a reasonable explanation for that. Catheter shear. That wouldn't be any good. Because that's the same thing as that's the same thing as like an embolus or a clot. We talked about circulatory overload. Some vasovagal reactions. There's your catheters there. 14 to 24. 24 itty bitty. And you'll have those patients that are like, "Can I get one of those small ones with the butterfly, with the little butterfly wings on it?" No, yeah, if it's not serious, then sure, you know that. If you're just using it depending on what you're using it for. And if that's all you can get, if that's the only thing you can get, take it. Oh, look at that. Scalp veins are best used in young infants. There's a couple reasons. They're not going to grab at it or anything else. They can't reach on top of their head a lot of times. So they won't grab at it, and everything else is easy to tape off. It's easy to see. It's easy to get a hold of. And kids, adults can be bad sometimes too, but kids have their mother in there or whatever guardian that they're close to have them in there with you and put them in that lap. Make sure that you have all your stuff ready to go and that you give that thing quickly. As soon as you can get them to look away, be calm, or anything else, you make sure you have a good grip and then let her rip. And make sure that you're ready to tape and everything else, because the first thing they're going to do is they're going to jerk that hand, and then you'll have a blowed line. And so you got to make sure you are ready to go, and ready to hold down or whatever you got to do. And you're going to get them. My own kid was one of them. He freaked out. So with using macro jips, how many times do you try to get a line if you miss? On a normal patient, 2. If I don't really, if it's one of those things where it may not be necessary, I do 2 times. I do 2 attempts, and then I'll just say, hey, we'll wait till we get to the hospital or something like that. Now, if it's a patient that I know needs it, they need medication or anything else, I'm going to get one. No matter what. There'll be something. Most of the time, your dehydrated patients, your severely dehydrated patients are going to be hard. Cardiac arrest patients can be hard, but I've already told you what my solution is for that. Diabetic patients, a lot of times can be hard. Children, they can be hard. People that are that are bigger, they can be tough to find one every now and then. You just have to be creative. Geriatric patients, sometimes they can be tough because the paper thin skin and the atherosclerosis or what have you, hardened veins. You'll take and those veins will roll and everything else. So you got to make sure that you secure. You'll actually feel it sometimes. The veins are so hardened. It almost feels like you're sticking it through wood. We don't use varicose veins. Don't use them. Don't try them. They have very little circulation. It's not good. There's an IO there. There's the drill there. There's in the manual PIU still used at all? Yes. I used one on a 2-year-old drowning victim. I used one on a 3-month-old, and I used one. This was just last year. I used one on a what else? I'm talking about manually. I used one on I definitely used one on a 2-year-old and a 2-year-old drowning and a 3-month-old infant. I used one. So yeah, we still use manual. Or you'll use this. What I did is I used this manually. No, you should be able to do an IO no matter what. Somebody say you couldn't do an adult IO? If you can do a peds IO, then you most definitely can do an adult IO. Oh, there's a sternal IO. Those are fun. Military uses these. No, you can do them. Extremely rapid flow rate. So if you feel your own leg, you feel the top of your leg at the tibia, and you can put your hand on it. I got a pretty good one. So you can take. Let's see which way. All right, so you can take from there. You can see how wide that is there. That is my proximal tibia tuberosity in between the fingers. So from there, that's where you can stick that IO right there in that flat spot. Big wide field area flat spot. Can't miss it. Shouldn't miss it anyway. Or you can do the distal tibia, and it's at the bottom end of that spot. Oh yeah. Humerus has got a faster flow rate. It's also with your other drugs, or it's also going to be right there close to where you're going, where all the work's going on. So, humeral head is the one that I prefer. Now, if they're working up top doing stuff, then I'll smack one down into the tibial tuberosity. So the tuberosity is the area of the bone. It's going to be the tibia. So the humeral head of the humerus, or the tibial tuberosity. Tuberosity is a landmark. It's a geographic location. There's the manuals there. Fast IO, fast devices. That's the one in the sternum. It's called the fast IO. And it is fast. There it is right there. Grab that thing, you punch that thing in there, boom, boom, just like that, man. That's a lot of damage. There's the Easy IO. Different sizes. So the pink, you got pink, blue, and yellow. Pink is for pediatrics. Pink pediatrics. And then you got blue, which is going to be like your normal sizes, your normal size adults. Most everybody, like I know on the military side, most everybody was a yellow. I used a yellow. And it's not because they're fat, it's just because they got bigger arms, bigger muscle. I'd probably be a yellow more than anything. And you drill it up to, you'll see these black lines on the needle, and that's what you're using for that separation there. You don't have to hub it out. You shouldn't hub it out every time. And what I mean by hub it out is you're drilling it so far in there, it's going straight to it's going all the way to the hub. you should be able to use the black lines, and that's going to tell you depth. Heck, you can even see right here, this isn't a big guy. Oh, too far. And they're using a yellow on him, which they said is, yep. Which, you know, he's not a big guy. They're using yellow on him. I didn't say muscles. I got chunky arms. Got them chunky arms right there, you know? There's a new one there, spring loaded. I have not seen one of them. That looks like fun though. There's the fast one. Make sure you follow the directions when you're performing the IO. Make sure you aspirate. By aspirate, I mean you're pulling some fluids out, and you're looking for, you'll see little bone fragments and everything else. So you aspirate, you unscrew, you put a fresh IV on, or a fresh flush on, and then you hit. You don't aspirate and then aspirate that little bit of bone and stuff out and then shove it right back in. You can aspirate, pull, put you a fresh one on there, and get you a good couple pushes. The push is the worst part. Extravasation of the needle, that's where you have a problem with it going all the way through, you're missing out on it. You start to put fluids into the interstitial space or fluids into the muscles. That's no good. Osteomyelitis, be inflammation of the bone and muscle, and it can cause infection because of an IV or an IO, I mean. There's some more possible complications. If it passes through both sides of the bone, you did a bad measurement. Yep. Osteoporosis, things like that, where you fracture the bone when you're pushing, or if you crush it on accident, just weak bones. Prosthetic limbs at an IO site. It's not funny, but at the same time, if you punch through somebody's prosthetic limb and you start giving them IV fluids through that prosthesis, you may have an issue. You may have a couple issues. First off, you're not going to fluid overload anybody. You're just going to embarrass yourself. I don't know. Maybe it was a wooden leg. You flushed the wooden leg. Hey, it's in there. If it's in here, that means somebody did it. You know that. All right, so mathematical principles used in pharmacology. So you'll need to have an understanding of some basic mathematical principles for this. It's going to be a little bit of review. So understanding fractions is an important part of a formula calculation. Fractions are expressed as a numerator over a denominator. You know that. The portion available. So what is available, and then total quantity. What is available, or what do we have on hand, and then total quantity. And decibels are going to distinguish numbers and so on and so forth. There are tons of YouTube videos that make this so much easier than just reading it in here. Medication math, things like that, they're so much easier. agree. Uh, Mainly, the big thing is once you get the math down, you're good to go. What you need to get down pat also is the grams, liters, meters, or milliliters, grams, milligrams, things like that. Make sure you have those down pat. That's why we check and recheck our medication math, and because what happens is you do not want to give the wrong amount by just messing up milligrams or micrograms or anything like that. You don't want to mess that up, that terminology. All right. So calculating drip rates. When you administer IV fluid, you'll need to calculate the drip rates, right? One of the easiest ways to calculate this is to use dimensional analysis. So dimensional analysis allows you to compare seemingly unrelated items by setting up a relationship and using ratios as conversion factors. So to calculate a drip rate, you need to know which medication set you're going to use. Are you going to use a 10, a 15, or a 60? The length of time for the infusion, how long are you going to infuse it for, and the amount of flow. You need to know that too. Remember that 1 hour equals 60 minutes. You don't say 1 hour, we say 60 minutes, or you say 120 minutes. So, for an example, if an order for 250 milliliters of normal saline over 90 minutes, okay, the administration set's going to be 5 macro drips, or 10 GTTS, or 10 GTT per milliliter. So to determine how many drops per minute, or to determine how many drops per minute should be given, you're going to put that GTT over how many minutes, right? And that's going to be 10 GTT over 1 milliliter times 250 milliliters over 90 minutes, right? So it's going to cancel out what you can and reduce the fractions. And we could get into this for a long time. I don't have a board in here I'd be able to show you. Talking about it ain't going to help you. $250 over 90 minutes. So it's going to be 10 GTT over 1 milliliter, right? And then 250 milliliters over 90 minutes. But once you get all the way down, to the end, it ends up being 28 GTTs. But like I said, there's videos that show you over and over and over. I may put some up on the website. Help us out also. Oh, I skipped one. So there are multiple formulas for calculating medication doses. The method of drug dose calculation demonstrated on here on the following three factors. You got the desired dose, you got the concentration of the medication available, the dose on hand, and then you have the volume to be administered. The desired dose is the amount of medication that the physician orders you administer to the patient, the medication that the physician orders you to administer to a patient, and that may be expressed as a specific number of grams or milligrams per kilogram of body weight. The medication concentration is the total weight of the medication contained in a specific volume. So you're going to note that the medications are contained in different volumes of solution, right? And this is your volume on hand. So to administer a medication, you must know the weight of the medication that is present in 1 milliliter. So weight per milliliter equals total weight of medication divided by total volume in milliliters. So an example would be a drug order. The drug order is for dextrose 25 grams per 50 milliliters. So 25 grams divided by 50 milliliters equals 0.5 grams per milliliter. Right? All right, we're going to take a 10-minute break from here. All right, we'll be back in 10 minutes. I think we skipped a break or two. Yapping. right, let's hit this back up. Home stretch. Right meow. I'm gonna post some stuff up on calculating medication dosages. So oral medications, you can see there. So an AMT for oral route, you're going to use aspirin and oral glucose, right? So use your standard precautions. Determine the need for the medication based on the patient presentation. Obtain a history, including any drug allergies. That's the big thing. Drug allergies. Make sure you follow your standing orders, or if you need to call in, call in. You got to document the medication that you gave. I'm sorry, back up. You want to check the medication to be sure that it's the right medication and not cloudy or discolored. And that the expiration date hasn't passed. Check the 10 rights of the medical administration, and then determine the appropriate dose. If administering a pill or a tablet, you want to instruct the patient to swallow the medication with water, and then monitor the patient's condition and document the medication given route, time of administration, and then their patient's response to that medication. And it talks about rectal administration of D50. The route of administration is going to depend on your local protocol. Some AMTs can give it that way. If the rectal administration D50 is allowed, it should only be used as a last resort when a patient is hypoglycemic. There's no other route that's an option. All right, so like IV access can't be established. And then check for indications, contraindications, and precautions before giving D50 rectally as well. Somebody's not going to be happy over that. There's given through any route other than the GI tract. There's some parenteral routes used by AMTs. Subcutaneous, IM or intramuscular, IV, IO, sublingual, transcutaneous, transdermal, and inhalation. Yeah, when they wake up, they're going to be mad. How did you give it to me? We don't want to talk about that. So if you're an ampule, it's a breakable glass. There's an etched ring around it, and you can break this top off, right? All right. So because that is breakable glass, what do you think ends up inside the ampule? Possibly broken glass, right? So there's a certain type of needle set or syringe and needle set that we should be using, and it's going to be a filtered. We should be using a filtered needle set or a filtered syringe, something to that effect. It's a filtered needle. Pre-filled syringes, easy for documentation. But pay attention to that. Not all medications, just because it's pre-filled, doesn't mean that you have to give all of it. Now, certain medications, yes, you do. Like Adenocard, yes, you do have to give all of it. Pre-filled syringes. If you look at the box with the pre-filled syringes, if you're trying to prep it for somebody, then look at it. There's a place on the side of it that'll say, it's for ripping out. It's to put your thumb in or your finger in and then pull up. That's the correct side. You'll get the hang of it. After several times you open it upside down, then you end up having to rip apart the entire box to get anything out. With everything going on, make sure that you keep track of all the drugs that are flying around there and how much. It's very easy to mess up documentation because there's so much going on. So if you're doing a sub-Q, 45 degrees. If you're doing 45 degrees in the subcutaneous area. If you're doing intramuscular, you're going to go 90 degrees to that muscle, straight into the muscle. There are common muscles right there. We went over all these routes. Whoops. All right, there's the inhalation, the nebulizer. You pour in, you're going to pour your fluids or whatever you're using, your albuterol, into this container here. And then from there, you kick it up, you let it flow. Main thing you want them to do is you want them to pull that completely in, full pulls. Breathe through their mouth. Get more in. If a child's crying, put it as near to their face as possible. And if they're crying, they're going to be sucking in. We talked about this. All right. And that is it for that. Let me look up here. Do we have any questions about anything that we went over? I know we went over a lot. And I'm going to post up some videos. Mr. Roy. Oh my gosh. That is an old picture. Where did that come from? That's funny. That's an old picture of me. That's from a long time ago. That was actually a very sad time. I was all dressed out because I was doing a funeral for a child, for a pediatric child patient that we had. But I spent 9 hours polishing that truck and getting my uniform together so we could be in the. So no, that was before then. That was before the VW days. But yeah, spent 9 hours polishing that truck and getting that all together. Fun. Redonkulous. All right. Trying to get the code up. What's today's date? All right, so today's the 4th, August 4th. The code today is going to be... Are y'all ready for it? Because I'm not. Now I am. The code today is going to be... $6765. That's going to be 6765. $6765. Nope, that doesn't go there. 6765. All right, everybody. Whoop. Sorry, Torrance. I sent that just to you. 6765. All right. I think that's it, everybody. Does anybody have any questions for me before we get off here? If not, then I'm going to stop recording.